oxandrolone or Anavar that is a synthetic molecule assortment of it. Just like we don't just have like 2 anabolic steroids, there are through kind of this like health bodybuilding genesis transformation about like having a picture of like the steroid genesis in their Instagram post or whatever and trying to explain, you know, all androgens are going to follow this same pathway.
All right, we are live with another episode. Excited for this one. We got Victoria Felkar. I was stalking her online for a little while there. She's pretty busy. She's in high demand, so this is going to be a special treat for our audience. So really appreciate you coming on. And as always, co-host Mr. Justin Harris. He's a little sad today. He's been crying all day. So give him a little break, guys, in the comment section if you can show him some love. He's just having a tough, just one of those emotional days Mr. Harris is having today.
It's been a rough one. I drew a duck earlier and it didn't come out how I wanted. You know, I'll get over it.
So Victoria, welcome to the show. Appreciate you coming on.
Thank you for having me.
So I know you, you know, a researcher in the field of, I know there's a lot we're going to talk about between women's health and androgens, estrogen, progestins, doping, all the above, all kinds of good stuff. So definitely for all the bros out there who think women are just little people, definitely tune in or little men, excuse me, they're not. So they are different. And I'm sure we'll get into some stuff that crosses over with men and athletics as well as we're coming here. Cause I know you've, you know, dedicated your life to this topic. You're speaking at the Swiss conference again. What is that? Like your 3rd or 4th year you're going to be there? Cause
something I have been since 2016. So
yes. Okay. I saw a post. It was 2020. So yeah, wow, that's even further back. So looking forward to that, and got some couple other conferences lined up. So pretty exciting stuff. And I know you make your rounds on the podcast as well. So
I try.
Good deal.
Try.
Do you have your topic for Swiss already, or same?
I know. We'll see.
Yeah, mine gets done on the drive down there.
Yeah, I love presenting and I love educating and I love Swiss because it is such an amazing opportunity to like share ideas with your colleagues and equals and the people that are just so hungry for knowledge. So I've gone there before and I've kind of tested ideas out, and other times I've done like different kind of approaches to it. I know back in 2016 it was really, I think, a coming out for women's health in the fitness industry, and that was such an amazing opportunity to have. Actually, Ken wanted me to do something totally different and I just was like, nope, not doing it. Because I was like, I can't just start talking about diet interventions if we don't get some of the fundamentals down first. So I don't know, this year we're playing around with some different ideas. So we'll see. It will be whatever it is. It will be probably never before talked about material.
Oh, nice.
That's what I tried to promise Ken every time I stand up there. So
there you go. Well, and
I promise Ken that I won't blow it.
You won't blow it. So yeah,
because he always asks for like a PowerPoint, because I'm not good at that, and so I'm always like, I don't have a PowerPoint, but you can trust me. I promise I'll fill the whole time with talking.
Yeah, I don't see that being an issue for you. I think you'll be all right.
Yeah,
you may have done it a few times.
Get me to shut up. Yeah, it's the hard part.
So just walk us through it. So I know for those who don't know, maybe they've been living under a rock or something, but you got, you know, your PhD in women's health and a lot of studies in the kind of hormone area. Just kind of quick version, right? Like walk us through, like, how'd you get started with that, and why are you so passionate about it?
Yeah, Cliff Notes version.
There you go.
So I am a doctoral researcher in sport medicine is my nebulous, I guess, the more basic way I can describe it. I'm part of the field or the discipline at UBC of School of Kinesiology. So it is that sport med, but I'm an interdisciplinary researcher. So I study across the disciplines. So from your hard sciences, biology, pharmacology, especially like more about applied practices, all the way to anthropology, sociology, history. So this big kind of mess of different ways of looking at the female body in particular, female athletic body, menstruation, reproduction, and drugs. My dad still, he's in his 70s now, and he always goes like, what are you researching again? I'm like, women and drugs. I think that's the easiest way I can describe it. So I got into this work. Oh gosh, I think my passion started really young. I was a female athlete growing up. I was a classical ballet dancer, had my own struggles with an eating disorder and overtraining, under eating, was put on the oral contraceptive pill at a very young age. And that really did change the trajectory of my entire life.
Sure.
Because of just the sum of all factors, which I'm sure we're going to get into all of that stuff, because it definitely is more of a nuanced conversation. But fast forward, got into strength training at about 15 years old. And this was in the time before women were training in the gym. It was still very rare to see like hardcore females at your just mainstream gyms. I loved it. My body soaked it up, especially from being in such a nutrient deprived state for so long and having crazy endurance from running and dancing, that when I did start eating and training hard, I got strong really, really fast. And then when I was 18 years old, my health took a dramatic turn. And all of a sudden it was being diagnosed with a whole slew of different things. Nobody knew what to do with me, particularly because I was a young female athlete. And that my hormone panels didn't look like your average female at the best of times, let alone in this very kind of critical metabolic and endocrine storm that was happening. And then I guess fast forward, I'm trying to really skip around here, but fast forward, I hooked up with John Meadows that same year, Dr. Eric Serrano, as well as met the guys down at Elite FTS and Dave Tate. And so very early in my trajectory, I had some amazing role models, amazing people that were helping to really cultivate my just curiosity and give me the confidence to move forward within the fitness industry, but at the same time, keep my roots in research. Because at that point in time, I was first year sports science student, wanted to go into medicine. Eric Serrano told me, no, go into research if you want to create change. And here we are today. And now I am trying to create change in this area because it needs it.
So were you in Vancouver when you connected with all those guys?
I was a 18-year-old from Vancouver connecting with the Ohio crew.
Okay. I think that is pretty cool though, because you hear these stories of like Dave and John and just having such, a big impact on people and helping people of all ages and all walks of life. I know, Justin, was down there when in his younger years as well. So it's just cool to hear that story. That's why I wanted to ask, like, how did you guys connect? Was it something like through online coaching with John, or how did that?
No, John didn't even do online coaching really back then. Yeah. It was, again, make a long story short, when my, body blew up, for a very condensed version, I gained 30 pounds very, very rapidly in the course of about 3 weeks. And of course, I was still like a total meathead bro, still trying to train throughout this. Went into my local supplement store, guy behind the counter, he'd seen me in and out, and he was like, yo, you've gained weight. And I was like, I know. You should talk to my coach. And his coach ended up being like just a really great kind of local level, national level competitor and coach, but he was on the forums. So he was on Professional Muscle, he was on Intense Muscle, and knew of this really great guy from the States called Mountain Dog, who was really smart. And he said, I really think you should talk to him. And gave me John's email. And so again, 18 years old, like before online coaching was a thing, John was still working at the bank. I reached out and was like, I hear you can help me. And right away, John was so honest with me, and he really said, like, I don't know what's going on, but I'm willing to figure it out with you. Right.
That's cool. What year range was that? What?
2007, 8.
Okay.
Yeah.
Does that sound familiar, Justin, from back in the Polaroid days of you coaching people?
Yeah. I thought, John, yeah, I almost forget he was Mountain Dog. It's weird how that works, you know, like you're Mountain Dog on the forums, or I was Troponin on the forums. And I guess I still have Troponin as the business name, and John still used Mountain Dog and stuff. But it's weird when they're like two different people in my mind, like the Mountain Dog that I would talk to on the forums that you don't see in person, and then you meet someone, and then they're John. And it's kind of weird how, like, hearing that name is kind of funny because I hadn't thought of that in a while.
Yeah, and here I was like back then I didn't know yet what forums were.
Yeah.
That introduced me to that whole world.
Well, you could, you can go one of two ways, because there are some really good forums like Professional or Intense Muscle, Muscle Mayhem, which I think was over by then probably, but you know, and then there were some bad ones that I don't want to say, but you get in the wrong one and you can get led down a really wrong path, or you get the right one and you can get led down the correct path. It was an interesting time.
I learned a lot about bodybuilding over those couple of years sitting on forums.
I remember the late 90s, like I competed as a teen and was just reading the stuff. Like, luckily I couldn't get my hands on anything, because like I would have, you know, probably hurt myself, because, you know, I mean, I like to think I wouldn't have, but it was just some of the garbage that was on there. You know, you're young.
There's still a couple forums that I go on rarely, and they're still like giving just terrible. It's always the PED advice is just terrible. It's good or bad. You know, the forums that were good were very good, and the ones that were bad were and are very bad.
Yeah.
Now, just back to kind of how this all started, the weight gain and all that. Was that tied to when you're on contraceptives, or was that separate from that?
Yeah. So essentially what happened was, and I guess I can start tying in some science here too, is that so a female's reproductive system is still developing at around 18 years old. So for the first 7 to 10 years after menarche or the first bleed, their reproductive system is developing. The literal framework for how that person is going to be able to create hormones, but also respond to them, metabolize them, transport them, bind them, all of that is happening. And then how the rest of the body is responding to those physiological occurrences. And so when you're put on the pill at such a young age, for me, I had only had 2 bleeds. My body didn't know left from right. It really had not been given an opportunity to actually figure out how to create hormones within my ovaries. Since as a woman, our ovaries are the site of most of our steroid hormone production. You do create steroid hormones at other sites around the body, but our ovaries are the predominant source. And so when you're on a hormonal contraceptive agent, even within, say, your 20s or 30s or beyond, you are shutting down the communication between your hypothalamus, your pituitary gland, and then your ovaries. And then there are changes that are happening in the ovaries as well, since you're not getting signals sent and received. You're not getting the same hormones bound and responded to, and even just the communication between the cell types within the ovaries. All of that gets altered. Now, you do that in a body that has yet to occur. Bad things are going to happen potentially when you also mix in other factors. So for me, I also had a horrendous eating disorder simultaneously. I also was overtraining. I mean, I was running, I don't know miles yet. I'm still transplanted to the US, but kilometers wise, I was running like, 8, 9, 10, and upwards of 18 kilometers every day and dancing 6-7 hours. Well, I was way overtraining and sustaining on like broccoli and breath mints. Wow. And so when you have that at the best of times, but when you put that in somebody's critical growth phase, you are shifting the literal like architecture of their body. And then you just start compounding epigenetics and genetics and other types of early childhood experiences. And for me, what happened was that when I came off the pill at 17 and then tried to get healthy, and then also had been in remission from my eating disorder, had been eating and training hard, not like smart, not stupid at that point.
Sure.
That my ovaries and the communication decided to try to fire up again, but my ovaries weren't having it. And so I ended up having at the end of the day, we don't ever know because we didn't do lab work at that time. But it was hypothesized actually by Dr. Eric Serrano that my ovaries tried to create hormones, my immune system responded, and then my metabolism followed suit. Because when I did get lab work done when I was in the hospital, because I ended up getting pneumonia, laryngitis, and bronchitis simultaneously, and then I had tonsillitis that became like antibiotic resistant. Then they couldn't figure out why. They finally ran a full proper 24-hour serum cortisol, diagnosed me with Cushing's disease because my cortisol, the endo was like, I've never seen anybody with cortisol like this. Did the brain scans, everything else. They thought I had either a pituitary or an adrenal tumor. That wasn't the case. But then when they retested, I was in Addison's range. So that's when you bottom out. And again, nobody could understand why and how dramatically fast it occurred. And so what, again, the hypothesis was, because we'll never be able to look back in time, is just that my body took a beating in a very short amount of time. And as a result, things happened. So my adrenal glands weren't working properly. My pituitary glands weren't working properly in terms of I wasn't creating growth hormone. I wasn't creating thyroid stimulating hormone. I wasn't creating prolactin. So all of these really essential hormones weren't getting made properly. And as a result, I didn't have a proper stress tolerance. I didn't have a proper even ability to eat, any types of foods. I was having massive glucose spikes and then insulin spikes and everything else. And it was through working with John and Eric that we were really able to hone in and figure out like what exactly was going on. And at the end of the day, these are things that are with me for life. Which it's not everybody goes through this. For me, it was the perfect storm that happened.
Yeah. And spiraled a lot of this, area of study for you, which is pretty cool to see, instead of just, I always like stories of people that, some things happen. They happen, different people, different times, right? But they don't kind of take that victim mentality, right? They try to figure out like, right, how do I turn some good out of this? How do I inspire some change through this? So I appreciate you sharing that.
I'm way too stubborn, to be honest. I just didn't want to get taken out of the gym. Like that was like, I was like, how can I figure out how to keep training?
There you go.
Because when the endocrinologists and metabolic specialists and everything else, they said stop training, and I was like, no, not like that's not an option. And I refused to accept that was going to be my fate. And Jen just started asking questions.
I got a couple of questions here, and I'll preface it with this. I understand you're a researcher, so I may ask, do you think, and you may correct me and say, well, the research says this. So I don't.
Yeah, Scott Stevenson's a good friend of mine.
I understand if you can't tell me what you think, but no, it just gets my wheels turning, right? Because I remember, back, I don't know if this is still the case, but a lot of young women, right? It'd be similar to giving young boys or teenage boys like testosterone, right? And a lot of young women are given estrogen. I've heard it for like acne reasons, right? And these reasons, has that, I know, and this is your area of expertise, so I'll let you comment on, of course. Like I know the studies for women research, a lot of the research was on men and trying to apply that to women, right? And we know that, men are on a 24-hour cycle, women 24, and then 28 to 32 day, a lot of differences, right? Is that still happening in younger women? Is that still, do you see it still being kind of misused, or is the research kind of better with that? It just seems very, it just seems poor. And I have two young daughters and family members that have went through that at younger ages. I'm just curious from a researcher's perspective, like what you're seeing out there.
Yeah. So a few things. I think we're in a really chaotic and crazy time right now within both research and particularly in the domain of women's health. It is a crazy, chaotic, confusing time, even for those of us researching it, because I don't think ever before we've seen such a polarizing opinions about certain things like hormonal contraceptives, even within the research community that is supposed to be unbiased. At the end of the day, I'm not anti-contraceptives, just like I'm not anti-PEDs. I am neutral. I believe that we need to be able to create informed choice through creating proper understanding and awareness about the risks, the rewards, and then contextualize it in an individual, because every individual is going to have different responses. And of course, we can't understand all the way down to minutia, but I think we can do a lot better of a job than what's been done in the past. And so to your point, initially, young men put on testosterone. think of a contraceptive agent, a hormonal contraceptive, as being more potent, right? It's like an anabolic androgenic steroid. There are molecules of both an estrogen and a progesterone that have been synthetically manipulated to create certain types of endpoints. Just like we have something, let's say, like oxandrolone or Anavar, that is a synthetic molecule of an androgen that has been created to have certain outcomes. You know, that anabolic and androgenic affinity has been altered. The way in which it gets metabolized hasn't been altered. It doesn't aromatize. And so the synthetic hormones in a hormonal contraceptive there's a massive assortment of it. Just like we don't just have like 2 anabolic steroids, there are so many different types of progesterones in particular that are within formulas. And then typically speaking, there's one predominant form of a synthetic estrogen used. And I'm going to start with that one because there's some really important takeaways here. So the synthetic estrogen that is typically within a hormonal contraceptive agent is called ethinyl estradiol. And that works different in the human body than estradiol. It has been supercharged. And so the way that it binds, the affinity is much more potent than the estradiol the human body creates. So it's binding to the cells, and there's different research that's been done. And I think a lot of it comes down to just some individual differences, but it's been hypothesized it's anywhere between 250 to 500 times stronger at the estrogen receptors. So if it's binding with that much potency, we know that those estradiol specifically, alpha and beta, are having a magnified receptor binding response. So we're supercharging this molecule, and then we're pairing it often with a progesterone. Now, there are some forms of oral hormonal contraceptives that only contain a progesterone, just like within implants and IUDs and vaginal rings. So there are progesterone-only contraceptives, and they have their own kind of different pairings with different suitable ages and indications and everything else. But the progesterones within kind of this big umbrella of drugs, there are about 4 to 5 different classes, depending on which kind of philosophy you ascribe to. Some of them are derived from testosterone. Some of them are derived from progesterone. And depending on what they're derived from is going to have different implications for potential outcomes. So, for example, when a progesterone is derived from an androgen, it looks more like an androgen than a progesterone. Like it looks more, or progesterone, I should say, it looks more like it. We call it a progesterone because you can't say that it's a progesterone. It looks too different. And that's for both ones that are derived from a testosterone molecule and ones that are derived from a progesterone molecule. The ones that are derived from testosterone molecules, they typically would not be used for somebody with like androgenic acne because they are having a more potent androgen receptor binding. And it's not an anti-androgen receptor effect. It is a pro-androgen receptor effect. But that progesterone, no matter if it's derived from a testosterone molecule or a progesterone molecule, does not act the same as progesterone. And that is such a hugely important thing to remember because we know that progesterone has so many amazing benefits for the female body.
Sure.
I mean, it's pro-thyroid. We're having such an important benefit for our brain health and brain chemistry. It's converting into GABA. And that GABA is having a massive role for supporting our nervous system. And so when you don't have that, you're not getting those same benefits. The progesterone molecules were created to have a particular potent impact on the endometrium and on the ovaries and shutting down ovulation. That was their goal. It wasn't to provide any other benefits.
So, yeah.
Mm-hmm.
I'm sorry. I was going to ask you, and are you seeing in the research different between progestins and like a micronized progesterone? Like I know that was a big criticism of like the women's health
study. Yeah. 100%. And if I could put more in than 100, I would, because there is a massive difference. I mean, it's again, I can speak, bro. It's no different than if we're talking about a bioidentical testosterone molecule versus a anabolic androgenic steroid, let's say tren.
Sure.
or nandrolone, right? A nandrolone molecule are a similar molecular structure to those progesterones that are testosterone derived.
Makes
I
sense.
like sit on that one for a second as gear users. It's just like, wow, okay,
Yeah.
we're giving these to 13-year-old girls.
Yeah, I
Right.
think
There's a lot there, and it's political.
some
Right?
guys might be getting ideas right now about
No, it's political. A big part of this is like, I can't lie in saying that there is a lot of information that does not necessarily get out there to practitioners, because if you look at the history of the oral contraceptive pill, there were certain pieces of information that have been suppressed from the start. And this is not me as a conspiracy theorist. I mean, I can open up any of the books on my desk or my bookshelf or articles on my computer and give all the reviews and DOIs and all that other shit. Like, there was back in the 1950s, it was a really big concern to women if they didn't have a bleed and if they didn't ovulate, because socially that was such an important thing. Think post-war, the baby boom, you were trying to reproduce.
Right.
That was important part of being a female in like a Western democratic society. And so when the women that they were testing some of these early drugs on stopped having a bleed, the drug creators were like, we need to fix that. That's what the off week is. That's all it is it was to fill a social need. Just like the suppression effects were really dampened by the creators, because when they were going and educating doctors were concerned. They're like, wait a second, we don't want to suppress women's ovulatory capacity. That's really important. So they started marketing it as a natural birth control. And so they changed the language to really hide these effects. And even today, there are so many practitioners that I work with that don't understand the complexity and nuances of not only female reproduction and ovulation and the importance of it, but how a hormonal contraceptive impacts that. And then also, if somebody doesn't have a well-functioning or a harmonious reproductive cycle or menstrual cycle, what can we do? Because in my opinion, and I know that the research backs me, at least a lot of the research now is backing me on this one, that it's not the best approach to just turn the lights on if we don't like how the room looks. We should do something and figure out why we don't like how the room looks.
Sure.
And that what we're doing when we put somebody on a hormonal contraceptive is we are turning off the lights. Now, in some instances, that's really important to do to get symptoms under control, or to stop certain cycles from occurring, or to provide some type of quality of life, or also just to provide reproductive choice. But reproductive choice for me does not mean giving somebody a drug that they don't understand what it does and what the long-term and short-term implications are.
Yeah, and I'm curious. I mean, gosh, there's so much we'll cover, but I don't know where to go. But I don't know where I want to go, because it's like a kid in a candy store. I got like 17 questions. But do you see either, I guess, a two-part question? Like, do you see any increase in the focus of estrogen metabolism being improved? You know, to your example, the room doesn't look the way we like it. And then A, and then B, is that truly a thing that's backed by research? And I can explain why I'm asking that if I need to, but I just thought I would throw those out there first.
Stay with me on this one. We're going to go on a journey here. So,
you ready, Mr. Harris? Sorry, I haven't let you ask a question yet. My apologies.
Yeah.
I'm good. I told you I was gonna just listen and nod. You guys are gonna talk beyond my sphere of expertise.
So, hormones, steroid hormones. And so when I say steroid hormones, I'm referring to androgen groups, estrogen group, and then progesterone and its metabolites. So that's my big three. There's other steroid hormones, but for our purposes, that's what I'm talking to. I don't call them sex hormones because they do so much more than just sexual characteristics, and sex is a really complex and messy term when we're actually looking at the biology of it. So when we're talking about those steroid hormones, there has been a historical, I guess, fixation on the fact that they are isolated, right? When we talk about the hypothalamus pituitary ovarian axis, case closed. It's not. It's part of so many massive interconnected networks. And that even something like the menstrual cycle, yes, the hypothalamus pituitary ovarian axis is an incredibly important part of it, but it's not the only part of it. There are so many inter factors and then external factors to the body that are going to influence somebody's reproductive capacity and their menstrual cycle, and then the harmony of the hormones within the menstrual cycle. It's so much more than just estrogens and progesterones. That's an endpoint. That's not a beginning point. And I think that's one thing we've gotten wrong, is that we've become so fixated on certain elements of it that we fail to look at everything else. So an example would be, for example, sleep. So sleep has a profoundly important role on how we create hormones.
Mm-hmm.
And not just our estrogens and progesterones and androgens, but the upchain ones, FSH and LH, so follicular stimulating hormone and luteinizing hormone. Also on our overall pituitary health. Also on our hypothalamic health and our nervous system, because our nervous system is what's above our hypothalamus and telling it what to do. And then if we go even a step further, there's a bunch of different neurochemicals involved. And so if we look at something like sleep, we know melatonin even has a massively important role on, just FSH and LH signaling, estradiol harmony between just the ways in which we are creating it in the ovaries themselves. Melatonin deficiency has been shown to be a really important thing to look out for in failed like IUI or IVF patients, just like vitamin D has been.
Mm-hmm.
And so I think that we kind of right now, especially in the fitness industry, although I love that we're talking more about women's health, I think we've got our narrative a bit closed off and a bit myopic. And in doing so, we've created such a, and I can swear on this program, right?
Sure. Be yourself. Be yourself.
Okay. Such a bullshit imbalance of like good progesterone, bad estrogens, androgens. It's like you get two different camps of people. Some people are like, polycystic ovarian syndrome, hyperandrogenism, bad. But use all the TRT and androgen. It's just like, what the hell are we doing?
Yeah.
Like, this is not okay. Because we're literally looking at hormones that are not ever in harmony in the body. They are high and low and ups and downs and here and there. And they're always moving, not only within each day, but in each cycle, within each life course. And so it just is such a complicated discussion that if we just focus on something like estrogen metabolism is not necessarily correct. With that said, yes, estrogen metabolism is a really important thing to talk about.
Sure.
Absolutely it is.
Yeah, no, I'm curious too, without, how do I put this? So I've looked at a lot of different testing diagnostic methods. Okay. Mm-hmm. A lot of times it was a biased group, if you will, presenting it, because most of the time it's the people selling it that were, respected in the field and experts, whatever. So I'm just curious too, when it comes to just high level women's hormones, do you see value in using, say, like blood serum at different times, and then using like a urine? Like I know one of the ones that I've seen a lot of is like cycle mapping, where they're mapping out the hormones over the entire cycle. What are some things that as a researcher you look at or see or find value in?
So I think it's going to come down to the individual.
Sure.
All too often people rush into testing without having the fundamentals in place. So for example, if you don't track your menstrual cycle, we don't have a basis to then be able to utilize to analyze your data. I think that with testing can provide a really great point of exploration, but it's one of many data we need to use. We need to also be doing like patient or client surveying. We need to also be doing symptom surveying. We also need to be tracking our menstrual cycle, particularly in women, for different signs like cervical fluid, because cervical fluid changes at different types of hormonal states. Things like libido and breast pain and nipple sensitivity and basal metabolic temperature. These are all really important characteristics that when we look at them as a collective, we can begin to better understand somebody's underlying hormonal environment, that then we can use testing as a tool to validate and also confer, and then from there be able to make better clinical decisions. The other thing too is that we have to put it in context. So as I mentioned, a woman's menstrual cycle is in flux. You will never have the same menstrual cycle. It will be different every single cycle. So if you're spending $700, $800, $900 on a cycle mapping and a bunch of serum testing, that's for 1 month.
Right.
Your next month is going to be different.
Mm.
So what are we gaining? What is the data we are gaining? What are we trying to gain, and what can we do with it? And that's where I think in some more complicated cases, these can be really important assets. Also, if somebody is utilizing HRT, particularly, let's say they're utilizing something like transdermal estradiol and an oral micronized progesterone, and they're still in their reproductive years, meaning that they haven't started to go through perimenopause, we need to be doing both, because we can't get an accurate reading on a transdermal estradiol from just doing serum testing. We have to be able to look at other and alternate forms of metabolism to be able to better understand. But then if we just rely on that, we're not getting our FSH and LH, which is really important, because as we're manipulating and using HRT, we're having a direct impact on their signaling. And we need to understand that more. We need to understand also how it's impacting other systems of the body. I can't tell you how many women have come to me over the years, and they'll be so fixated on their hormonal values that they'll fail to recognize, like, hey, I can also utilize things like your complete blood chemistry and your lipid panel and your thyroid. Like, these are all really important pieces that are not only going to give me data in their own right, but when we look at them collectively, we build a much bigger and better picture. Also for women, like, I think that ovarian ultrasounds are incredibly important, because they're almost like and again, this is a terrible metaphor, so please nobody take this out of context, but if we think of A1C as being a longitudinal marker of our blood glucose, think of a pelvic ultrasound of giving us more of that longitudinal look into where somebody's ovarian hormone environment has been, and plus their endometrium, because estrogen, estradiol specifically, and progesterone are impacting our endometrium. We can use something like endometrial thickness to better understand how somebody's hormonal milieu has been over the last few weeks to months, and even back more. So there are many other measures as well that actually help to build out the case in a better way. But our hormones are always changing. So going back to, like, let's put it into an example. If you've got a female competitor that has just come off a competition season, and that she's been dieting really hard and had a significant body recomp, and has also been utilizing certain PEDs, Sorry, China Mainland just called me. I never get spam. But why would it make sense to run labs like a week or 2 weeks or even 3 weeks after she gets off stage? It doesn't. Why? Because if we're manipulating things and moving things forward into that kind of more health-focused domain, her reproductive system is going to be shifting and reforming as a result of this. We're going to get more FSH and LH signaling potentially. We're going to get those actual follicles in a healthier place where they can start to make hormones again. And so I always recommend that we wait at least 3 months, build the foundations first, and then if we're not moving in the right trajectory, we go in and we test to get a better assessment, but we do it in a very strategic way. We don't just throw shit at the wall and hope that it sticks. We actually think about, what are we trying to gain from this? If somebody has not had a bleed, has not had any signs that there's any type of hormonal shift, their discharge is non-existent, and they haven't had any breast changes or anything like that, then why would I run progesterone? She hasn't ovulated.
Mm-hmm.
Like, let's save you that money. That just doesn't make sense.
Sure.
It's absolutely such a silly thing to do, because it's, maybe if we get some really rare things that I'm seeing, we might run it down the road, even if they're not ovulating. But in 15 years of doing this like consulting and research, it's very rare. I think I've seen that once in one case. That's it.
Yeah, and I know, Justin, it sounds really similar to I know what you've done with a lot of your male competitors, right? As far as testing, is it usually about the same time period when you're looking at?
Yeah, I mean, mine's a little different because what I'm just trying to make sure they're not dying. It's with the male bodybuilders, so it's more, I need to what I do is make sure that when we drop down to TRT or cruise after about a month or so, that their blood work, like their lipids and things like that, are within a range that's more acceptable, because I know they're not going to be really in range. It's going to be very difficult to have a good LDL, good HDL when you're on a full contest prep cycle. So I want to verify that we can quickly get them back to within range by putting their hormones back into what they should be, like TRT level testos. A month of that, are you in a normal range or very, very close to it? If not, then we're getting too far out of line on your blasts, and we need to rework things, because it's going to just continue to drift in the wrong direction.
Got it. Yeah. And Victoria, is there I don't know if it seems to be more with female competitors. So I got kind of two questions for you. And I hear this from some of the coaches where like a lot of, I won't say a lot, maybe it's just like a confirmation bias, whatever, but more women athletes are like one and done, because they seem to be coming out with a lot more metabolic issues than men after shows. I think that's like my first part of my question. And the sub part to that is, I'm sure you're going to have a detailed response to that. So if you remember, the second one is a little bit more about PCT with women coming after show, like, is that needed? Yeah. And just generally, what have you seen, or what does that look like? So those are kind of my two thoughts after a show for women.
Okay. So there's a lot there.
There's a little soft.
Yeah, there's a lot there. So, okay, let's go back to my own story here. So when I was growing up, I was put on the pill prematurely. That changed and altered my reproductive function, but also the system surrounding my metabolic, my immune, so on and so forth. You put a body like this into a contest prep setting, don't expect that good things are going to come from it.
Right.
Right? Everybody is different, and everybody's going to have different responses. By and large, my philosophy is the healthier you are before you start a contest prep or a prep for some type of athletic endeavor, the better we can ride the storm that we're entering into. It's a basic fundamental philosophy, especially in neuropsych, called reserves. And it's that that you're going to be depleting your reserves through the activities that you're asking of your body. High levels of training, low levels of food, altered micronutrients, PEDs, psychosocial stress, so on and so forth. Your bank account is dropping. Mm-hmm. And so the more we can build up your bank account before we start a prep, and even create a surplus, the better we are going to be able to go into that prep. I am seeing so many people starting contest prep in bankruptcy. They have nothing to pull from. And even if their food is like, 2,000 calories, and they're not doing cardio, their other parts of their health is not where it needs to be, because health is not the absence of disease. They might have an anovulatory cycle to begin with. They might have altered, let's say, peripheral insulin response because of having a eating disorder during their reproductive growth years, or their major growth spurt, their from that kind of puberty phase. You might have somebody that has already kind of an underlying anxiety that's not been either diagnosed or treated properly through therapy. Don't expect that these things are going to get better when you're prepping for bodybuilding. That's not going to happen. And that for some people, we can create literal cellular epigenetic changes through what you're doing in that prep. That is not okay at all.
Sure.
So that's the first part of my question, is that like, I see men that get messed up. I get to see women that get messed up.
Yeah.
I think that there's a lot of women right now that are already not in a good state reproductive wise before they begin, and they maybe don't recognize the impact of this on their entire physiological and psychological health status. And as a result, they don't realize that that is going to have implications for things like fat loss, or for how they are able to put on muscle, or how they are able to just manage the overall stress load.
Problem, I think a big problem with the females, so many females get into the sport with a male coach or male boyfriend or male trainer, and very few people know what they're doing as far as hormones. But if you're a male bodybuilding coach and you're doing the wrong things with male hormones on men, there's not much you mess up. You know, if you give the guy a cycle that's not that great, maybe his estrogen's too high. It's not. But you do
get
the
a
wrong.
Little gyno and call it a day.
You get surgery. You do the wrong things with females. It's a much, and they have no clue. They have no clue what to do with the guys. So they have no clue what to do with the females.
Yeah. And there's so many fallacies around women's health, particularly in the fitness industry, like this idea that certain hormones are good and other ones are bad, or that no menstruation isn't anything to worry about, or, hey, you have been somebody that's been on oral contraceptive, let's say for 10 years, and it's an anti-androgenic progesterone and a high dose ethyl estradiol, like a high dose synthetic estrogen. And then you add in androgens on top of that. Like, I'm sorry, but you are setting that person up for blood clots. Like, it is terrifying, absolutely terrifying. Plus, not to mention, they're using an anti-androgen that's far more potent binding than the androgens that you've also told them to take. But you don't have the knowledge to ask them, or the understanding of what implications that might have on their physique development in the first place, because there is such an ignorance around it. And I think that, Justin, you're totally right that, women, we know so little about a lot about the human body, but when it comes to women's bodies in the fitness industry, that gets exponentially bigger. And I see it all the time, because I get the women that come to me after they've seen, all these different coaches, and even high level coaches that don't have the knowledge and the understanding, and that the solutions that are often given to them are like, well, maybe you shouldn't compete, or maybe you should go back on the pill, or maybe you should just take some more Masteron and Proviron and call it a day.
That's the thing. It's like they don't realize that women need estrogen, because you do a male's contest cycle. Let's get you can't go wrong if I just take estrogen to 0. You'll feel terrible, but we don't have to worry about water retention. That's great. Well, then they'll do the same thing with women, and the same thing like with like Anadrol is harsh for men, but it's harsh because it's so watery, because it's so estrogenic. But with women, a very low dose of that might not necessarily be so bad, because the estrogen isn't so bad for them. I mean, estrogen is not bad for anyone. It's healthy in general, but it's just it's basically, they just do. Here's what I give my male clients. You're half the size of them, so I'll give you half the dose of the exact same stuff.
Yeah.
This episode is brought to you by First Detachment. First Detachment is an expert formulated supplement company founded by renowned coach Justin Harris. We've combined science with real-world experience in each product. We are battle-tested. Are you? Find your battle today at firstdetachment.com.
Or there's a lot of, I think, ignorance too, just around individual response to androgen binding. We have this idea, and it's so funny, because I remember when coming up into bodybuilding, and I feel like I've been a part of this through kind of this health bodybuilding genesis transformation of, just everyday bodybuilding coaches talking about having a picture of the steroid genesis in their Instagram post or whatever, and trying to explain it. It's like, you didn't see that thing anywhere 10 years ago. That wasn't a conversation. But there's no critical thinking. There's no actual deeper dives into the research and the understanding of it. So they're taking this idea that, all androgens are going to follow this same pathway not recognizing that no, steroidogenesis happens differently in different tissue sites in the body. How you create androgens in your ovaries, in different cell types in your ovaries, is different. There are 2 different types of cell types in our ovaries, and you create androgens and you respond to them, you bind them differently. And that's just in your ovaries, let alone all of the other paths in the body that we know about. And there's a whole hell of a lot that we don't know about. We know very little about androgen binding, particularly in the female body. We don't understand that in men, it's now been documented quite clearly that there is something called backdoor androgen synthesis, where there are some people that just create androgens alternate pathways, that they don't go through the normative kind of, okay, we have DHEA, DHEAS, we've got that kind of upper top, we go down into testosterone, and from testosterone, we go back and out into our branches. Not everybody has that normative pathway. And so we know that there are some women that have some type of a heightened physiological binding of certain androgens, but not across the board. Some women, you look at their labs, that they can actually have relatively low levels of testosterone, but their androstenedione can be up the freaking roof. And you start asking those questions of like, okay, where is this coming from? Well, that's because in their ovaries, one of those cell types is creating more androstenedione, and it's more responsive to luteinizing hormone than it is to follicular stimulating hormone. Follicular stimulating hormone helps to create testosterone in the ovaries and DHEA, and that creates estradiol. So you can have a woman that's got actually relatively low testosterone, low estradiol, but her androstenedione is jacked up through the roof. That's not going to create a physique that is worth like standing on stage. You're going to be watery, you're going to be hairy, you're going to have massive issues with insulin resistance, you're going to have a really hard time losing body fat. You might be strong.
Justin's
maybe.
been telling me all this stuff. So Justin, it's confirmed. I need to track my menstrual cycle, and I need to take care of my water and my hair, and
No, but what you're saying right there is what I'll see. I see coaches give PCTs, like a post contest or post cycle therapy, to females where they're taking HCG and Arimidex, and like what you would do for a male PCT. It's like
terrifying.
Yeah, and they're giving this like like as a doctor, like prescribing it essentially to.
And it's terrifying because we know that with PCT with women, that the drugs that get used in traditional male PCT get used in fertility treatments. Right? I think we all can agree with HMG, HCG, Clomid, but when you, depending on the individual we're talking about, and depending on what types of drugs they've been on or maybe haven't been on, that let's say Clomid can have a very altered response in that person. You can cause something called like ovarian hyperstimulation, because essentially you've had a bunch of eggs, which is how we create our follicles, that's how we create our hormones, that have been arrested in a particular phase because you're not getting the proper signaling and the nutrition and everything else, and the environment outside the ovaries is much higher in hormones than inside, so they just kind of hang out there for a little bit until we get the conditions back in place. Will you give that person HCG, HMG, Clomid, you create all of a sudden a hyperproliferative response that then they actually will create an abundance of follicles, and we start to create stuff like polycystic ovarian syndrome, or we create endometrial hyperplasia that then we cause a massive disruption, and all of a sudden that person is having huge amounts of menstrual bleeding with clotting, and that creates massive amounts of inflammation. And it's like, it's not one size fits all when it comes to PCT. There is absolutely no one size that fits all for women, because we don't know their background. We don't know if they've been on some type of hormonal contraceptive. We don't know where their starting place was with their hormones. We don't know how their just even basic receptor response was before they got started. There are so many questions there that we have to answer before we dive into, now, how do we get things moving again?
I want to ask a non-specific science question for a quick minute, just for our audience out there. So your consultative services, are they to coach athletes actually for a show, or do you just focus on people that are messed up and then what does that look like? Like, how do you help them not be so messed up?
So
I'm sure a lot of people will be interested in
yeah,
like connecting with you after the show. So
I
just
still
curious.
work with professional athletes,
Mm-hmm.
but sometimes I feel like it's a bit of a conflict of interest for me at times because what they're asking, my health brain is like, especially when they're like contract athletes and you're just like, oh, I get that you have that photo shoot, but so I really don't love working with in-season athletes as much anymore. I will under certain circumstances. I also work a lot with coaches. So that's a way that I can provide insight and information that can be used in more of an applied way. But I'm not here to teach you like biology 101.
Sure.
That's not me. I'm very selective when I work with both professionals. I work with clinics. I work with different practitioners as well. And usually there's some degree of base knowledge to begin with, because unfortunately you got to do that. You got to get messy on your own.
Right.
You know, when somebody asked me once, like, what's the best textbook to learn about women and anabolic steroids? I said, go get some just basic endocrine and gynecological textbooks and start learning. Because that's, and pharmacology, like that's how you have to start. You need to have that base knowledge to then be able to apply. When it comes to individuals, I work with a lot of women that, I mean, it's a wide spectrum, everything from like, they've gone through the gauntlet of going to different practitioners and nobody can understand what's wrong with them. So they might not have a reproductive support with their care team, but then I get brought in and I actually get to work with them and their care team. Other times it's that, you know, that female, let's say pro athlete that's done competing and is like, I'm 35 years old. What have I done? Like, I don't like where I'm at.
Yeah.
That's a common one for me to work with. And it really varies too. Some people, it's one consultation and done because I can guide them. Other times, I mean, I've got people I've worked with for 5 years.
Right. Yeah. Good stuff. So just going back to female competitors or, you know, as you mentioned earlier, like, gosh, I remember in the early 2000s as a trainer, taking women over to the free weights. Right. And it was just like, I don't want to get bulky. Now it's like, there's like 10% of dudes and you got, you know, the women are outlifting, at least for the lower body for sure, more than the men, which is pretty cool to see, but kind of, but
terrifying at the same time.
Yeah, I know exactly. As I say that, I'm like, well, I guess, you know, yeah. But my question is there anything you've seen out there that is maybe puts a female athlete at a lower risk? Like we kind of anecdotally have some ideas for men of like an age to, if they're going to do it anyways, is there some kind of time in their, you know, maturation, you know, over the years, et cetera, like of when it's like, well, generally this is less, you know, again, there's always risk, right? But
yeah, it's funny. I was just talking about this with my husband like last weekend. It's such a complicated question because the reality is we have young women being put on steroids and getting their reproductive axes shut down, and we have a literal like infertility epidemic as a result. Like fertility clinics weren't a thing until about 15 to 20 years after the hormonal contraceptive got introduced. So we can sit on that and think about that one for a second. That's kind of wild. But for me, how do we create less risk? We get healthy, we stay healthy for as long as possible. And what healthy looks like is going to be different for the individual. But what we know is that the steroid hormones, having the proper blend, harmony of them is incredibly important for an individual's health status, both short term and long term. And it's not just about fertility and making babies. Because I have so many people that come to me and they're like, I don't want to be fertile. It's like, well, no, you actually do. You might not want to conceive, and we can figure that one out. But you want to be in a place where your body is making and creating a harmonious blend of steroid hormones. That's really important because that's going to make it so when you do utilize certain compounds, you can do it safer. I mean, progesterone is a fantastic anti-DHT. That's pretty cool, especially on the skin. So when we're talking about facial hair growth and cystic acne, progesterone helps to manage that. But we can't just add progesterone in during a contest prep because it's converting to neurochemicals in your brain. And if you've never been exposed to it before, that can be really scary.
Yeah.
So we want to try to get somebody in the healthiest place before they begin and try to keep them there. And remember that the target that we're trying to hit is going to change. I have worked with some of the best female athletes like on the Olympia stage. And there are very few women I've worked with at the highest level that maintain an ovulatory menstrual cycle all the way to the bitter end of a competition phase. Very, very rare. There's one person, and she is a phenom. But she did reduce her progesterone. So her cycles became more what's called a luteal phase deficiency. The lower her body composition, the more that training, the lower the food got, the more that the stress hormones got, the less she was sleeping, all the things that come with prep. And so, it's not this like sexy thing to say, but it is. It's like, get healthy and stay healthy. Make sure that your body can utilize food properly. Make sure that your mitochondria are just working at the best capacity possible. Make sure that we don't have any holes in your boat because you're going out to sea, right? You've got to be able to do that first and then to try to maintain it, knowing that you're probably going to have shifts. That's going to happen.
Yeah.
So be proactive as possible.
No, I appreciate that. I got a lot of kind of compartmentalized questions here. So if anytime you have to tap out for time, just let me know. Because First question, you mentioned progesterone in a contest prep. Is the thought process, I'm sure there's more than one, but is it have to do with some of the effects it has on insulin? Is that kind of why they want it lower? What is it related to? I know it's more like calming, restorative. I mean,
so if we think about like let's just say like the phenotype or like the perfect menstrual cycle in a woman, we have two main phases, and those phases can get broken up further. And I do actually employ people to look into that, because if I have my whiteboard out, I'd be breaking it down into more phases. But you have your luteal phase is the second half. You have your follicular phase is the first half. So when a woman has a bleed, the first day of the bleed is the first day of the menstrual cycle. At that point in time, her hormones are actually at their lowest. Your hormones are at their lowest when you have a bleed, because that's what causes the bleed. The withdrawal of hormones creates an instability of the endometrium, which causes it to slough, and you get a bleed. So testing your hormones on day one, not the smartest, or day two. And day three, while it is an important thing to gain insight into how the pituitary gland is responding, it's not the best to actually understand where somebody's estradiol is at. Your progesterone, you wouldn't measure it on day three. And when it comes to androgens, I mean, again, we're going to not necessarily get where you're at when they're at the highest, because we're still building back up again. So that is, though, happening in our follicular phase. It's happening in the first half of the follicular phase. As we travel through our follicular phase, estradiol is going to be going up almost in a bell curve, and then it's going to drop. When it is at its highest, that signals luteinizing hormone to release in a high amount from the brain. And so that's follicular phase. And then we reach mid-cycle. Mid-cycle, when everything aligns, we have enough estradiol, follicular stimulating hormone is in the correct amounts, luteinizing hormone has been bolus dosed. If everything is happening, everything is aligned, we will be able to go through something called ovulation, which through that process, again, I'm not going to get into too much nuance here, but that's how we make progesterone. If all the stars align, though, we can have cycles that we don't ovulate. And if that's the case, throughout the second half of the cycle, we are not going to produce progesterone. If we do, though, in that second half, that luteal phase, progesterone, again, it's going to come up to very, very high levels. When you see most of those graphs on the internet, they're actually not labeled correctly. Progesterone rises 800 to 1,500 times more than it does at its baseline. So we go high and then we drop down low. Estradiol, meanwhile, it's still being produced. Again, those graphs you see are often very inaccurate because they usually will show estradiol as being really low in the second half. That's not the case at all. You are producing estradiol in the second half of your cycle. And when you have a correct ratio of estradiol to progesterone, you will not have any magnified symptoms.
Mm-hmm.
It's that ratio that is so important. If estradiol is really low and progesterone is really high, you're going to be symptomatic. Just like if estradiol is high relative to progesterone, you're going to be symptomatic. And so when we think about something like a contest prep setting where somebody might have lower levels of estradiol because they're not creating that egg that's going to be able to create testosterone and DHEA, which is going to convert into estrone and estradiol to begin with and create that estrogen in our ovaries. If we're not getting that and you just give them progesterone, they're going to feel like shit.
Mm-hmm.
Like, because you created a physiological imbalance.
Yeah, it makes sense. Is there, are you familiar with, hopefully I say her name right, Allison Vitti, Vitti. There's a book in the flow out there that's.
Yes.
Okay.
I have probably read every one of those books. I think I have 3 on my desk right now.
Well, my question was generally,
Yeah.
Is there any in the research, anything you
Mhm.
see validity as far as like the type of, let's just start with training, like the type of
Mhm.
training based on where you
Yeah.
are. And that's like, okay,
Yeah.
well, that pretty
Zero.
much settles that.
Zero zip. And when I'm in the event in Australia, I'm going to be picking that apart.
I guess I should have started the episode with that question.
Yeah. I mean, it's all based on pseudoscience and
Right.
myths around the female body.
Yeah.
If you look back in time, even up until, I mean, honestly, up until now, some people around the cultures around the world still believe in that you cannot pursue activity during the menstrual bleed. Whether it's because it's unsanitary or unhealthy, or your pelvic uterine ligaments can't support that heavy, endometrium, whatever the kind of the myths and mythologies are, they exist. But it wasn't that long ago that women were not allowed to engage in physical education during the bleed. And if once they were, it was only after day 3 or 4 of the bleed. They weren't allowed to compete in certain sports or activities. And so all of this has created such folklore, especially within the world of physical activity and nutrition, around what you can and cannot do, that's based off of really nothing. And at the end of the day, your menstrual cycle is different every single time. And I see so many women in the athletic community perceiving that they actually are ovulating, and they're not, and they're basing their kind of training around some BS plan that is all around like, well, luteal phase says it's going to do this, and this is what we see with progesterone. No, show me the research.
Yeah.
It doesn't, it's not there. It simply is not there.
Yeah, I know there's a lot in there. Like she talks about carbohydrate intake at different times and different types of training. One's more like restorative type training. One's more your hit and intense. And I was just like, interesting. So I was just curious what.
There's nothing. And it makes me so sad because there's some really great researchers out there that still promoting these beliefs. And I just go like, show me the research. Yeah. Because I mean, if you guys could, like, literally, I have stacks. Like, I have binders like this beside my desk of articles, and this is just on like myths around training in the menstrual cycle. Like, and that's not my computer is disgusting. I hoard articles because I want to find answers. I want to see, can I find where this makes sense? And if you look at even around like elite athletes, like their latest study says, like, there is insufficient evidence to promote training around your menstrual cycle. Now, your own menstrual cycle, that's a different story. But when you take this template that assumes that you have a normative, harmonious ebb and flow of estradiol and progesterone, and wait, what about everything else that's happening? Like, they just don't make sense.
Well, there you go. Just blew that up. So good deal. Glad we can clarify that though from someone who actually, is digging through all the research and looking at that. So, all right. Speaking of research, got one more specific question here. It's on oxandrolone Anavar use. So if you haven't seen this or this isn't familiar, I will find it and send it to you. Cause I had a pharmacy share this with me once. There's research. It was a study on women using low dose, like your general population, like low dose Anavar 2.5 to 5 milligrams, like a
Mhm.
troche form. So it didn't
Mhm.
elevate their liver enzymes, things like that. And it seemed to, I don't know, work well to oversimplify the study, right? But
Mhm.
have you seen that used as any kind of protocol if, like, say a female they're not menopausal,
Mhm.
but they need to increase, that
Mhm.
need, but their
Yeah.
testosterone is absent or really low, so that using that kind of as a way to try
Mhm.
to elevate that. I don't know, it's been a while since I've looked at that. I was just
Yeah.
curious if that's something that's familiar in your area of study.
Yeah. So, like any steroid hormone, whether we're talking about estrogens, progesterone, or androgens, the way in which you give it to the body is going to elicit different effects.
Sure.
Injectable versus oral versus sublingual versus vaginal versus rectal. I mean, there's many, many different forms of administering just a single hormone. There's a chapter actually in my research on this because it is something that I think gets really forgotten. Even though you're not by getting the same kind of liver metabolism when you use sublingual, you're still getting like a huge impact on SHBG.
Right.
Oxandrolone is hugely liberating
Yeah.
for SHBG. So
Right.
we have to ask, like, what would be, even at 2.5 to 5 milligrams, it's hugely liberating on SHBG. So
Mm,
we have to ask, like, what would be the implications of that for an individual, and what would be kind of the more of the positive outcomes of doing that. For certain people, liberating SHBG, let's say after long-term oral contraceptive use, particularly when they're on an anti-androgen and have been for 30 something years,
mm,
when used appropriately, can be a really great tool, but it's not long term. And it's not even for muscle building. There's a very strategic way in which you can apply it when it comes to, say, bone density. So I work with a lot of women that are either pre-osteoporotic or osteoporotic because they've been on long-term contraceptive use. There are some different types of kind of androgens that can be useful, but again, we have to go back to like who. Another thing is that 2.5 to 5 milligrams is still going to have a different effect on individuals across the
right.
board.
Sure.
You'll
Yeah.
have some people that have more of a heightened androgen receptor sensitivity, and they might have certain types of kind of outcomes that you would see with another individual if they were on 20 milligrams,
Mm,
because there is such a variance there, and we have to look at like how have they been exposed to hormones over time.
right.
Have they had like normal androgen production? If not, then you have to go very carefully towards the use of even something like oxandrolone at 2.5 milligrams, because you just don't know how that person's going to respond to it.
Sure. Yeah, I actually seen it used, and again, this is anecdotal. It was with a physician who was trying it with someone. But they used low dose oxandrolone because they had high total testosterone, but
Mhm,
extremely high SHBG and low free testosterone. So they used it
mhm,
to try to. I'm theorizing here. I
mhm,
wasn't the prescriber, but
mhm,
because of its high binding affinity to SHBG, it would, like, the theory was, and it seemed to
mhm,
work in the blood work, but would bind to the SHBG, therefore like allowing more free testosterone to kind of do its
mhm,
thing. So, it's just something that I came across, and it seems that there's, obviously we talk a lot about on the men's health side, like declining testosterone levels in
mhm,
men, but I've seen it a lot in, well, I say a lot, but in uh I wouldn't say in
mhm,
research, but just in patients in my
mhm.
former work, where they're coming in, women with a lot of low testosterone and stuff. So that's why it's just an
Yeah.
area of curiosity
Well,
more for me.
I think it's like a really important area too, because right now there are so many different types of like hormone replacement clinics that are, I think, helping to create more of a less of a stigma around androgen use for women.
Mhm.
But I don't think it's necessarily moving in the right direction, to be
Mhm.
honest, because I'm getting the cases where drugs have been used by a prescriber in an HRT clinic to a woman with devastating consequences
Yeah.
because they haven't actually taken into consideration, like, why is their testosterone low?
Low. Yeah.
Is this a temporary phenomenon because they've been dieting? Is
Mm.
this a temporary phenomenon because they are in a super high stress phase of life?
Mhm.
Like, our hormones aren't stagnant.
Right.
And if anything, it's particularly in that like 20, 22 years old to 35, 38 years old, we need to have harmonious levels of androgens, estrogens, and progesterone. Like that is when we are literally like that reserve idea. We are building up those reserves.
Mhm.
And so if we're not, we need to ask questions about why. And I see in my line of work, like there's so many individuals that contact me that they don't need me, to be honest. And I tell them that. Like you need to get healthy.
Sure.
Because the reason why you have low estradiol, the reason why you have low testosterone is not because there's anything pathological going on here. It's because you have, you know, a cell phone addiction, you have no boundaries, you have really crappy relationships, you don't have any investment into your self-worth or compassion for yourself. You're struggling with an eating disorder because you're carbophobic from that contest prep diet you did 10 years ago. You're
Sure.
still training 3 hours leg workouts 4 days a week. And it's just like, we need to get healthy. Drugs aren't the answer.
Yeah.
Drugs can be really cool. They can be a great vessel. They're a tool in your toolbox. That's all they are.
Yeah, I went on a vessel one time with some shrooms.
Well, we got a 3-second reel that we can pull out of that one, Dustin.
I gotta say something stupid every podcast. It's
No, it's all it. We'll put it in the highlights. So
yeah, the highlight. Yeah, put in the low lights. You know,
no, just overall. I mean, I think I know we're over on time, so I want to be respectful of your time. I really appreciate you coming on. But one thing I think I would like to walk away with, you know, either for the men who are coaching friends, significant other who are women, or just, you know, the female athletes out there. If you had your hit list, call it your top 3 or top 5. Like I think we usually end this in a different format, but I think given your expertise, I'd like to end on that. You know, what would be some of the bullet points, key takeaways with where you are right now?
Yeah. So number one is to really gain an understanding of where a woman is at in their reproductive health and menstrual cycle health and function. And it's really easy to do. You track. And tracking can give us such valuable data. And I'm not talking about using like projective, like ovulatory apps that exist now. Like get a thermometer that has 2 decimal places, or there's lots of different devices out now. I mean, there's a great company from Australia that's got a ring that's ovulatory specific. It's called Femtech. There's Temp Drop, which is an armband, so you don't have to stick your thermometer in your mouth first thing in the morning. But because progesterone is thermogenic, you can get incredibly valuable data about whether or not somebody is, number one, ovulating, number two, having some sense of ovulatory capacity for a certain duration of time. So if you see that they have a 30-day cycle, but they are only having an increase of temperature for 6 days, that tells us that they have an insufficient luteal phase length, because we want to have a relatively even matched follicular to luteal phase length. You put that together with things like cervical mucus or fluids. You put that together with moods and kind of breast and nipple sensitivity and just hunger and overall kind of well-being scores, and you can build out a really great picture of where somebody is at in their menstrual cycle, and then you can utilize that if you need to explore extra testing routes. So you can utilize that once you have that data to go and get your, let's say, progesterone, estradiol, and androgens and FSH and LH done in the middle of your luteal phase, because you can get it done when you know your hormones are going to be or at a projected place. And now we actually have something to utilize to be able to analyze that data. I am so sick of people coming to me saying that their hormones are low because they've measured them on day 1 or 3 of their cycle. And it's just like, of course they are. Like, yes, of course. And so I think if we can just take that and utilize that, because going into a prep, that can be such an amazing tool to have. Because if you start that prep and you know that your luteal phase length is usually on average, let's say 18 days, and your follicular phase length is usually 18 days, and this is your normal, and these are all your normative signs. You see your cervical mucus getting more fluid and viscous in the first half, and then it gets more egg whitey at mid-cycle, and then it gets drier and tackier in the second half. If this is your normal, when you're healthy in your off season, you can now use that as you go into your competition season to see how it starts to deviate. And if it starts to deviate too fast, like if you're, let's say, 4 weeks in to your prep and you're already seeing in that cycle really big swings and shifts, we know we probably aren't going anywhere good with your menstrual cycle. And if that's the case, we can begin to try to create some type of intervention plan that makes sense for the person. So that would be number one. Number two is drugs aren't the answer, not all the time.
We can edit that part out. I'm kidding.
Uh,
No, I'm teasing.
drugs aren't the answer, not all the time.
Yeah.
Sometimes, and like, I'm not going to be, in my ivory tower being like, shame on you for using gear. It's like, no, I'm very realistic about this, but I'm also just seeing, I come from the land of bro bodybuilding where like there was no upper limit talked about.
Right.
And that women's use wasn't a thing ever talked about. And now I'm seeing this world where it's so weird because all of a sudden, excessive male use is frowned upon. And there's this like lower limit of like TRT only. Yet women, it's like, you're using 8 compounds? What?
Right.
Like, it's just such a weird time that we're in. And it's not okay. At the end of the day, we're not in an okay place as a fitness industry. You remarked on like, it's great seeing more women in the industry, but unfortunately our knowledge and understanding isn't there to support this growing number of women and of competitors.
Yeah.
And they may look good in that moment, but there are all the women that you see on Instagram that are looking awesome. There are just as many that are not looking awesome and that are not performing well or healthy.
Well, I think I just want to comment on the drugs aren't the answer thing. Like I say that joking, of course, earlier about it, but I it's the same thing with men, especially younger guys too. It's like, okay, so like, you're going to do this, your first state show, but yet, you're maxed out to the gills on all these drugs. Like, what are we doing here? So it's common in both, but like you said, I think because there hasn't maybe been, there's for whatever reason, to your point, there's been this push, and maybe it's because a lot of the deaths in the sport and people passing and things, but there's been this push for like the upper limits, as you talked about, in men. And I don't remember hearing that in the early 2000s, but with women, you're right. I don't hear that at all with women.
And use is getting concealed now. We are thrifty creatures. Like, it's like, you see more women where women used to stop when they would have certain types of like virilization, whether it's jaw changes or facial hair growth. And now, because of the cosmetic industry, you can change that in an instant. And so where you used to have these very vivid visceral signs of, hey, things aren't in a good place with your kind of androgen levels, people are bypassing that now. And when I see something like virilization, let's just say facial hair growth, that's the end point of a whole bunch of physiological processes that have occurred long before you start to get that hair growth there. It is like that, that metaphor you see of like the plant growing and then the soil below. It's like that hair growth is literally that plant growing. And there are so many different things happening below the surface before that it had even popped up. And so by you just lasering that off, you're completely ignoring that. And I think there's so many different practices around men's, steroid use that are getting talked about, like, therapy at phlebotomy or getting your labs done at the proper time, things like that, PCT. And the conversations for women are either muted or they're just filled with myth and folklore and bad information. And it's not actually helping us move forward. If anything, I think it's holding us back.
Yeah. Well, I mean, it sounds like you got a pretty booked agenda to help, straighten some people out. So well, you're going to be busy. You're going to be busy for a long time. It's with how quick the sport's growing. So, but no, I really appreciate you coming on. I know in all seriousness, you do have a lot of, talks and things you're doing. And, for everybody out there, Victoria Felkar, on Instagram or victoriafelkar.com. Tons of great information. And I like on your site too, this is something we started doing not too long ago, but you have, your podcast and things that you're on there so people can easily just really eat up your, all your information that's out there. So any other, closing, thoughts or questions from you, Mr. Harris?
Well, you'll be at Swiss, Victoria, but are you doing any other, you have anything else planned already for the year? Any big conferences or anything?
Yeah, so I am heading to Australia in 2.5 weeks, I think, for the Ultimate Evidence-Based Conference. That is in Melbourne. So that is in August. I think it's the 12th and the 13th. And then I have, I believe, an online, I think it's called the Women's Biohacking Conference in September, and
Yeah.
it's just online.
I think, yes, someone told me about that.
Yeah, and it's a free event, but it's just to try to get more conversation in the women's health world. And then Swiss in October. I guess I'm going to be busy these next couple of
Yeah.
months, aren't I?
Yeah.
And turning in my dissertation. So
Oh yeah,
we've got a busy
definitely
time ahead of
busy.
us.
Yeah, have fun with that.
Thanks. I need it. Yeah.
Well, thanks again, everybody, for tuning in to 1D Talks. Victoria Felkar, for your time as well. And just a reminder, everybody, to like, subscribe, and you can also find the podcast on all of the audio platforms now too. So we're pretty excited about that. We'll be posting this out there, as well as quite a few reels and shorts and quick links, so that everybody can be sure to check out all the information we talked about today. So thanks so much, everybody, for tuning in. We'll see you.
Thanks.